This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best. So hello and welcome to the Nupsala Podcast. Today we're joined by Dr Jason Lowe, who's the Chief Veterinary Officer for Contura. And today we're going to do something slightly different, and we're going to have a discussion around his 2024 paper, Histologic and Cytologic Changes in Normal Equine Joints After Injection with 2.5% Injectable Polyacrylamide Hydrogel Reveal Low-Level Macrophage-Driven Foreign Body Response. Long title. But thanks for joining us today, Jason.
Thanks for having me. It's great.
Well, it's great to have you on. And as I said, this is slightly different for our podcasts, but I think it's great that we're actually going to get right into some of the research that's been going on over this hydrogel. So it was an observational in vivo study where you were characterizing cellular changes in the synovium in response to the hydrogel injected into the equine joints. That's correct?
Yeah, that's right. It was part of the safety arm of our pivotal study for market authorization with the authorities in Australia and New Zealand. So it was data we'd collected reasonably early on, and we just hadn't published it, but we decided to pull it together and published it in 2024, just as a sort of segue as we were starting to understand a lot more about the gel and how it interacts with the body. And I think so that was the real motivation behind it, because I think once you understand the gel, you understand how to select the right cases, and that's quite important for the veterinarian.
Yeah, absolutely. So can you just give us a brief overview of what the study was?
Yeah, so basically we had 10 healthy horses. These, again, in safety trials, you're just looking for adverse events, right, against a product to get it registered. So we injected multiple different doses into different joints. Again, under safety studies, you're looking at 1 times, 2 times, 3 times the sort of recommended dose. That's just so the authorities can check if there's an accidental overdose, is that going to be a problem? Do we have to have label warnings around that, et cetera, et cetera? We then did serial synoviocentesis samples, so taking joint fluid samples out of those joints at specific follow-up periods. And we took some of the horses through to euthanasia, as we could collect synovial tissue samples and really dig into what the gel was doing and how it was behaving. There'd been previous studies done in multiple different species, pigs, goats, rabbits, but there hadn't been anything specifically in horses at that stage, although there was another paper by Christensen that was published around 2012, which did have some horse data in it too. But again, looking at it from a regulatory point of view, we also managed to do scanning electron microscope work, which was really, really cool to dig in at almost that molecular level to see what was going on and how it was integrating. And like I say, it just gave us a real much better understanding of the gel's behaviour.
Yeah. Oh, wonderful. So the title suggests that there was this low-grade foreign body response. Can you just tell us what that is? What do you actually mean by a foreign body response?
Yeah, for sure. Look, it's really interesting, right? Because I just think in veterinary medicine, it's not very well reported like this, and yet it is in human medicine. But this is when we implant materials, devices, bone screws, bone plates, collagen, all sorts of things into the body. And we do that quite commonly, right? But I don't think anybody really understands that the body responds to those devices in a particular way. And obviously, if you get a overt immune response, you can end up with a granuloma or a fibrotic type reaction. And that was recorded with some of the earlier hydrogels. I mean, when I first started looking at this product, sort of in the early 2010s, you Google search hydrogel and it was horrendous because we just saw all these really bad cases of granulomas and fibrosis and infections and stuff. And it's like, wow, why would we put that into a joint? This is crazy. And so, but that's not what happens with this gel because of its unique physicochemical properties, which is down to the manufacturing and the way that Contura make the product, very carefully controlling the conditions to which these sort of long chain molecules lay down. So it's very regular, very what we call homogeneous. So when you look at the scanning electron microscope, it's this lovely regular honeycomb pattern. And so the body just initially comes in with macrophages to have a look at the product. And then it actually goes, oh, well, okay, yeah, it's not too bad. I'm actually quite comfortable here. This isn't causing me a problem. And because we know now that what it's doing as a hydrogel is restoring the elasticity and softening the synovial membrane, the body ends up just accepting it. So it integrates. It doesn't have a long-term response, but it is by definition inflammation. But that is part of the integration or implantation process, if you like. And I think that's why really understanding it, it's macrophages, it's not neutrophils, it's not, we don't want acute inflammatory reactions. Again, that would be bad. This is just macrophages. And it's low level. So at no time in the study did the levels actually go outside normal laboratory levels. So it's a low-grade cellular response, peaking at around, and this is why we took serial samples, peaking at around 2 weeks and then backing off again as the body accepts the gel and things start to calm down. And we went out to 90 days in one of the patients, which almost looks completely normal compared to control joints, with just the gel sitting there quite happily, that the macrophages, like I say, have gone and had a look. Nothing to see here, guys, go away. So they'll just sort of regress, or they'll actually turn into new type A, type B synovial cells. And that's where we see the changes on the joint lining. We get this sort of reformation or restoration of a nice healthy synovial cell layer facing the joint, and obviously that's critical for restoring the joint function, if you like, which has been damaged in the disease process. So.
Yeah, okay. So vets reading this, shouldn't be concerned that they're seeing the words foreign body response. There shouldn't be anything that's they should be worried about.
I think that's it, and it's certainly been, I guess that's why I was quite keen to talk about this paper, because it has been tried to be used against us, and some of the earlier studies, I sort of mentioned the Christensen paper before, and some people were looking at the histology of that and saying, well, that's fibrosis, that's not what we want. And I get that, and I think there's a whole shift in the paradigm thinking around what is inflammation? What is the body trying to do to heal itself? Because I'm convinced that the body does want to heal. But the problem, especially with osteoarthritis, is it doesn't heal. It never sort of catches up on itself. And that's why we get this sort of vicious, degradative downward spiral with OA. Whereas if you give it the right environment, the body will heal. So yeah, this is not an overt foreign body response. That's how it's defined in the literature, in the human literature. And so that was the terms that we used in reporting this paper. But it raises absolutely no safety concerns or red flags. This is just normal part of how the product ends up integrating into the synovium.
Okay. You mentioned that people have been concerned about fibrosis and granuloma formation, and that's what maybe you've seen previously with other products. Did you find any evidence of that in this study?
No, and that was a really good thing to confirm. So especially from my point of view as a veterinarian and as a researcher, that would be a massive red flag. But no, there was no evidence of that at all, and quite the contrary. The neutrophils were good, and it was very much, as I said, with the different types of hydrogels, because you can literally make higher percentage hydrogels are relatively easy to make. They actually use like a 30% polyacrylamide hydrogel to cap oil wells in Texas. Okay, so these hydrogels are used in all sorts of different applications, but in medical applications, we want something that will mimic the human tissue, and that's what I call biomimetic. This product, the viscoelastic properties of it actually mimic natural tissue. That's why this particular hydrogel just causes, well, no safety concerns, or doesn't raise safety concerns across multiple species. As I said, it's now widely used in humans, dogs, horses. It's also been used in experimental studies in rabbits and goats and stuff. It just mimics mammalian tissue, so it's really cool like that.
So what were some of the other key findings from this paper?
I think really the sort of the main one, that was that sort of transient response, like I say, that came through. It sort of really defined with the scanning electron microscopy work. Just you could see these sort of particles of hydrogel just beautifully integrated with the host tissue. So these collagen fibers networks sort of snugly holding it in situ. So again, you don't get any migration of the product. So I think that was really cool as well, and so just the lack of adverse events, etc. There was also a lot of concerns raised around neurotoxicity, and early on, because acrylamides are highly neurotoxic, and that's well reported, and this is a polyacrylamide. So I think there was a lot of sort of urban myths around, hey, this product could be neurotoxic, maybe that's why it's working so well. So in our study, we didn't specifically do nerve stains, but we've certainly seen that in other papers, and there's more recent publications sort of confirming that. And there's some more coming out this year from Colorado State University have also looked at this. But again, understanding how the gel works and how stable the molecule is, it was really, really cool to see.
Okay, brilliant. So based on the results that we have from this study, what are the practical recommendations that you can give to vets that are using this out in the field? Is there anything that came out of that?
Yeah, I think it really started to help us understand where the efficacy data had come from, which sort of showed this. In our efficacy study, we did 2, 4, and 6 week lameness exams. There'd been a previous study by Aziz Nibar in 2015. They'd done 4 weeks, 12 weeks, and then out to 24 weeks, which is 6 months, and then 12 months, and then actually out to 2 years. But there was sort of, when you looked at that data, you sort of saw this, there was something happening in that 2 to 4 week period. So I think that's why we, with this study, we actually managed to say, yeah, well, it takes 2 weeks to integrate into the synovium. So it takes 2 weeks to have its clinical effect, and even out to 4 weeks. So from a practical clinician's point of view, don't make an assessment on if it's worked or not until that 2 to 4 week mark. Because we're used to, with potent anti-inflammatories like corticosteroids, the owners, the vets, we have this expectation around a real rapid response, that horse is better in a day, 2 or 3 days. It doesn't happen with this gel. It's quite a subtle sort of improvement in clinical signs, and that's because it's going through this integration phase. And I think with that as well, it's, if you can, back off the horse in that time. We don't want to be galloping these horses and having them in high speed disciplines or activity while this integration process is happening. Now, in our thoroughbred pivotal study, we did exercise the horses. The trainer and owners were blinded. We injected the product, they got rested, and then they were straight back into training. We saw no adverse effects with that. But it's sort of beside the point. The point is, we're treating a lame horse. put the product in, give it a couple of weeks to work. So just back off these horses. And what we find is that we sort of seem to see a better response for longer if we do that.
Okay.
And I think it also fits beautifully with the welfare aspect, right? We shouldn't be injecting horses and working them hard. They're lame, back off them a bit, manage the horse.
And that fits with everything that we know about what's going on in the synovium and the joint as an organ at that time, isn't it? It's been chronically overwhelmed, unable to control its own homeostasis, and now we're putting something in that is hopefully going to support that, but it needs that time, doesn't it?
It does, and say the new work that's coming out of Colorado State shows that we sort of have this peak effect again around the 2 weeks, and I think it's just tying in with we restore the biomechanics. That takes a couple of weeks to work. We're then getting these lovely sort of secondary or downstream effects where we start to see the inflammatory profile of the joint fluid change. And like you say, it just ties in beautifully with how we can manage the disease much better, and starting at that sort of foundation of it, fixing the biomechanics with a viscoelastic hydrogel, and then the body sort of sorts everything else out because it's had a chance to catch up on itself.
Yeah, that's it. And what about dosing? Vets often ask about dosing. There was dosing of kind of 1 to 4 mils within that study. So what's your recommendation?
Yeah. So it's a really good question. Look, we've got some more research. We're actually having a meeting in the next few weeks to discuss dosing as well, how we can map it out. Look, the best way to describe it, I guess, is we know that it has a primary mechanical effect in the synovium, so restoring joint capsule elasticity. So if you have so I think vets got to get it. We got to get away from joint volume specifically as a dose indicator. It's more about the stage of pathology that we're dealing with. So in a real chronic, stiff, horrible joint, I would be going for maximum dose. So a fetlock or a carpus, I'd be putting 2 mils, maybe even 3 mils in. If we've got a very early onset joint with no radiographic signs, we just have reaction deflection, some synovitis, capsulitis, then 1 mil is going to give you a good clinical effect. And I think the other thing is reassessing your response to treatment around that 4 to 6 week mark. We've given it time to do its job, but hey, it's a partial response. It's better, but it's not 100%. So top up the dose, put some more in. There's nothing wrong with that. And again, I think we've got to get away from this concept of just, inject and walk away. We should be back into managing these horses and looking at them regularly, talking to the owners about it and thinking about what's happening inside that joint now that we have a product like this.
Yeah, that's it. There's no product out there that is the magic bullet, as you say, that will just cure everything. OA, we know, is a long-term disease, and it's going to need long-term management. So yeah. And so, based on the results, if a vet was to be managing what they might call a flare, and I'll say that in inverted commas because there's lots of interpretations of the word flare. What do you think, what would be your advice to start them off?
Yeah. Again, I think this is where this paper, to me, gave a much better understanding of how we should be managing these, because historically, any flare reaction has been considered infection. Right? It's sepsis and treated as sepsis, and regardless almost whether it's proven otherwise. And I think when you look at the studies, we very rarely culture bacteria out of joint flares, but probably because a lot of them aren't septic process. They are literally a flare reaction to a product or to an intervention. And again, whatever we stick into the joint, and even saline, okay, if you put saline into a joint, you still get a flare reaction to it. You'll still get an inflammatory response because the body it's foreign material and the body reacts to it to come in and have a look. So with this product, you can get non-septic flares, okay, so a sterile flare, because it is a big molecule, it's a big chain molecule, you get this macrophage response, and if the body comes in and that's sort of an overt response, then it can present absolutely like a joint flare or a joint infection. So rule out sepsis. Sepsis is sepsis. If you see bacteria on a smear, if you get a culture, which, like I say, is, less than 50% of those will culture anyway, but treat it as such. And obviously, you would go to arthroscopy, and you'd probably be putting intra-articular antibiotics in there and treating it quite intensively. But with this product in the market and being used more and more, I think vets have to, if it's in the case history, vets have to say, okay, well, maybe this is a sterile flare and it's just a reaction to this particular product because it's a big molecule of stuff, hydrogel. And so rule out sepsis and then treat it quite conservatively, because what I've seen is if you go in aggressively with these, and we've had surgeons want to do synovectomies and tear out the lining of the joint and put in basically acidic antibiotics. A lot of the amikacins, gentamicins, they're quite acidic. And so you're just sort of insulting this joint more and more, right? And you just wind up that flare and you make it worse and worse. Whereas backing off them, combination non-steroidals work really well if you get a flare with this product. And so I'm talking like phenylbutazone and paracetamol, firocoxib, sort of combination therapies. And there was a great paper out a few years ago talking about the different combinations that we can use. And just, be a little bit more patient, be cautious, because you don't want to wind that joint off the spectrum, basically.
Yeah, so from this study, has there been, what's the future of the research that you would want to come out of this paper?
Yeah, so we've sort of got the next step, because what really intrigued me is macrophages, right? So we haven't seen, it's not been documented before about macrophages and their role in, them coming in response to this gel. And then it correlated up with some work from Bruno Manarum. He's now at University of Kentucky doing some research, but a paper of his came out, it was around 2021 that it was published, and I think it sort of got lost in the COVID global pandemic, right? Because it was an incredibly insightful paper to me, and starting to build up this concept of M1, M2 macrophages, good macrophages, bad macrophages, good inflammation, bad inflammation. And the fact that, say, inflammatory response, the inflammatory cells coming in to the osteoarthritis joint, they're coming in there for a reason. They're actually wanting to sort out the cytokine levels, because as we said before, if you get inflammation in the joint, then that's going to degrade the cartilage and release more pro-inflammatory cytokines, and that vicious cycle sort of winds up. So looking at the macrophages, tying it in with Dr. Manarum's study, we've also got Colorado State University and looking at what's called the transcriptome. Okay, so this is brand new technology where we can actually now measure cellular pathways. Okay, so not just looking at cytokines in a joint, because we just haven't been able to find that magic biomarker that says this is definitely OA and this isn't. But the transcriptome is sort of heading that way and actually getting down at a deeper sort of genetic level, looking at the RNA pathways. Because what happens in human OA, animal OA, these pathways just take off and, like I say, wind up the joint and cause the destruction and stuff. And I think the stem cells and all the different products that we've tried to use, orthobiologics, it's almost like it's too subtle. We've been trying to block off one of these pathways, but if you block off one of these pathways, another pathway just opens up, because you haven't treated the fundamental underlying issue with that joint, is that its biomechanics are failing. because that horse has got bad conformation and it's galloping too much and it's getting older and it took a wrong step, whatever, but it's that repetitive cyclic load that we know starts to damage these joints. And so that's where the 2.5 iPAAG is sort of a foundational treatment to sort out the biomechanics and restore that. Then we get these lovely downstream effects, how it starts to shift the transcriptome and the cytokine balance. And I think the macrophages are tied up in that. So that's, again, where we wanted to get this paper out there as a nice segue to where the research and the data was heading. So I think there's more to come on this. It's pretty cool. But it gets pretty technical, gets a bit over my head, I must admit. But it's very cool as we start to unlock, I think, a lot more about OA, what it is, and how we can manage it. So.
Yeah, absolutely. I really look forward to reading those papers, and they'll also be over my head, I'm sure. Now, I always end my podcasts by asking my guests what 3 things you would like our listeners to take away from this podcast. As now, I haven't prepared you for this, so this is going to be off the cuff.
Yeah, no, that's great. It's a great question. Look, I think number one, this is a very safe product. So I think the urban myths and the rumors and stuff out there, they're flying around on forums and chat places and stuff. Do your own research and look into it. This is a safe product. Don't just take my word from it. I'm the CVO. But seriously, in that role, I deal with pharmacovigilance across the world. And it's just really rare that you have an issue with this product, cross fingers, touch wood. And that's really important to me as a veterinarian. So I think, and to all of us, right? We've all been there when things go wrong, and none of us want that to happen in our careers. So I think safety is number one. I think number 2 would be understand the molecule. If you look into the 2.5 iPAAG molecule, understand the manufacturing criteria. It's all under GMP in Denmark. We bring people out to the factory quite often, and they all walk away going, wow, we had no idea that all this goes on just to make this one little syringe of hydrogel. So understand the molecule, because once you understand the molecule, you'll understand a lot more about what the product's doing inside the joint. And my third thing, I think, again, would be, if you understand the molecule, you then understand the cases that you should be using this in and how to use it. And I know we have shifted practice in Australia, New Zealand. We've been working with this for over a decade now. I have colleagues in Europe, the US as well. When it sort of first came onto the market, even, horse people alike, it comes into some back channels and stuff really early on. But the results speak for themselves, but it does take you a little while to get your head around it. So I think, be patient, try and understand it, but you won't be disappointed. And then my sort of thing is, yes, if you've got a 2.5 iPAAG treated joint, then it just becomes a way easier joint to manage. I'm not saying you won't need other products in there, and I still use orthobiologics and other things in practice. But once you've got the iPAAG in the joint, it's just easier to use. And it will become sort of foundational in your treatment of OA cases. So I think those would be my 3 things. It's a long-winded reply, but
fantastic, thank you. Well, it's been great talking to you and understanding that paper a little bit more. I had read it a few months ago, and then I read it again today to make notes, and it's great to then have somebody take you through it. So are there any other resources, papers that you think that vets listening should turn to?
I think the latest data, that came out of the research at CSU, that's been presented on podium now at the ICRS conference in Boston, was also on podium at the AAEP in Denver. Those abstracts are available either through reaching out to us or or onto those conference websites, they just really start to give us a much better understanding of the mechanism. And again, I think what surprised us all in those studies, and the researchers in particular, was treating the synovium, how that is protecting the cartilage. And I think that was I think it's a big step forward in our understanding of, because everything's always been focused on cartilage. But again, it comes back to, let's address the underlying cause, which is the biomechanical failure of these joints in the synovium. And you made the great comment before about the synovium is the organ of the joint, right? It's the heart, lungs, and liver of the joint, because that's what it's doing. And if you get a healthy synovium, it's producing healthy joint fluid, and that's cushioning the joint and lubricating the joint and protecting the cartilage. And now we've got the scientific evidence to prove that that's what it does. So I think that again is a real step forward for human medicine and for veterinary medicine, and how we're coming together as a One Health sort of forum on that. Again, because this product's been used in multi-species, it's quite exciting.
Yeah, the narrative has definitely changed. In the last kind of 5 to 7 years that I've been working in the kind of OA field, messaging has changed, the narrative has changed. So well, thank you so much for joining us. I will put any links to any papers, I'll put those in the show notes so that people can refer to them. But thank you very much, Dr. Jason Lowe.
Thank you very much for having me.
Thanks for tuning in to the Nupsala Podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts and Amazon Music. Simply search the Nupsala Podcast. You can also watch on YouTube or directly at nupsala-learning.co.uk. If you'd like to stay up to date with all our latest content, please follow us on social media, where we always post when a new episode launches. All the links and details are in the bio. Thank you.